Okay, I'm going to start with Professor David Ross Khamiges. He's at the University of Colorado, Arizona, and he's written an editorial. It's actually called Controversies in Thoracic Oncology in JTO, Journal of Thoracic Oncology. And he says, uneasy lies the head that wears a crown. That's a statement by William Shakespeare. And I just thought what befits more than this sentence to start, and it's his opening of the editorial as well. So to discuss the optimal sequencing of ALK TKIs in the management of advanced NSCLC, ALK positive, I'd like to request my panelists to join in. Dr. Mukesh Bang from Nagpur. He's on Zoom. Hello. Okay. Welcome, Mukesh. Dr. Rahul Kulkarni from Pune, also on Zoom. Yeah, right here. Welcome. Dr. Udip Maheshwari. Not here. Preetam, Dr. Preetam Kataria. And Dr. Rup Jyoti Sarma. So we have, okay. So Dr. Rahul Kulkarni and Dr. Rup Sarma, yes, and Preetam, of course, I know, and Mukesh Bang, Dr. Mukesh Bang is from Nagpur. So essentially, as we go through this, rapid fire session, we are talking about sequencing of ALK inhibitors, and we all know. Good evening, sir. We all know that. We all know the crown data. We all know the crown data, and so we are all familiar with the fact that lorlatinib has had an advantage, and it is one of the standard of cares here to stay. Now, alectinib has been there forever. It's been there for a very long time. This is 8 years I've been in India, and prior to that, ALK study, I was one of the PIs at Columbia Presbyterian. So even before ALK, through the phase 2 studies, and through ALK, through the phase 3, and post that. So now alectinib for over a decade, and now lorlatinib coming in the same space with the data that you've all been privy to for the Crown study. So we start with a case. This is a 50-year-old Indian woman, non-smoker, presents with left back pain, severe breathlessness, cough, and you see a solitary tumor in the left lower lobe, moderate ipsilateral pleural effusion, moderately differentiated adenocarcinoma, EGFR negative, ALK positive, PET-CT with spinal mets, and this is a classic presentation of advanced NSCLC, ALK rearranged. And the patient is found to have brain metastasis, and first, even before the patient gets sent to the medical oncologist, maybe to Dr. Kulkarni, before he's sent to you, he is already radiated, or she is already radiated. So what's the first line option here for you for this patient?
So already treated with CRS metastasis, obviously, as you said.
Mic not working.
Yeah. So already, as you said, the patient has been treated for the CNS metastasis. Maybe I'm assuming she's not very symptomatic for that right now. Having known the Crown data, definitely we know that lorlatinib at this point has a little advantage theoretically. But having said that, alectinib, we have a very good clinical experience. So I would like to discuss both the options with the patient. And considering the comorbidities, the patient's condition, I will take a case-to-case decision. So in this case, maybe an elderly lady, I don't know the comorbidities. And with the prior clinical experience of alectinib, I would like to start with alectinib and then maybe reserve. But having said that, I will have to discuss both the options, and maybe in case-to-case basis, I can offer lorlatinib as well.
Excellent. So that brings to the front, what are the key factors that you consider when selecting the frontline therapy? Do you look at the PFS, OS, CNS, long-term data, quality of life, resistance, availability, money, etc.?
So I think all the factors come into picture at some point of time. We know that both the drugs have now sufficient long-term data. Even lorlatinib has now 5 years data which has come up, and alatinib of course has long-term data as well. We also look at obviously OS and PFS are important, but the tolerability is also one factor, and the patient comorbidities as well, where we need to discuss and decide which drug will be better suited for that patient. And of course, cost is a major constraint in our country. So ultimately, at the end, it boils down to the cost. So if cost is not a constraint, then I think we have to choose the drug which is best suited for that patient.
Well said. I think we all look at the PFS and the OS, and all of that makes up our mind and approach to a patient. Would the others want to take this? What are you looking at? Are you looking at the side effect profile? Are you looking at PFS, OS? Preetam, any thoughts?
So yeah, ma'am. So we both look at the PFS OS data as well as the side effect profile. The tolerance is going to be an important aspect in choosing the drug. So yeah, so that makes a difference.
So this particular patient, thank you, Preetam. This particular patient, what would be your thought? What would come to, you're looking at the PFS curve here, and we have the comparison with the ALK study, and we have the ALK study, and we have the Alicia study, and we have enough Asian data, and you look at the PFS, and then comes in, of course, the PFS from Crown, and then in the vicinity of that, the overall survival, a 5-year overall survival. So what are you thinking? What are you really thinking as you think ALK positive NSCLC, what really matters?
So efficacy and toxicity both matters. So in this patient, the patient has CNS mets, which is one of the important considerations. And patient has also received WBRT. I think that will be WBRT. So we will need a TKI, ALK TKI, which will penetrate to brain, and which has a very good CNS penetration and CNS overall response rates. So if we see the third generation TKI, lorlatinib versus alectinib, lorlatinib, the data for CNS looks better, and but when we the ALK, it was positive by IHC, so I don't think NGS was done. So had NGS been done, it could have picked up any T50 co-mutation was present or not. So in this patient, because I think the patient is affordable for both alectinib and lorlatinib. So in patients who has received WBRT, those patients, if they have received lorlatinib, then they had more CNS side effects. So alectinib would be a preferred option. However, if the NGS showed TP53 co-mutation or variant 3, then in this case, lorlatinib would be preferred.
Okay, those are great points. CNS, pre-radiated disease, higher chance of toxicity, all of that. So finally, you're saying you'll look at the toxicity profile and take a call.
Yes.
Because you feel the drugs are similar, different?
Toxicity was third generation TKI is much more toxic than alectinib.
Preetam, you wanted to say something?
So one of the things that we would look for is the fusion variant also, which ALK fusion variant is there. And based on that, because if the particular fusion variant may be sensitive for lorlatinib, then my first choice will be lorlatinib. So alectinib and lorlatinib would be both options could be there. So one would like to sequence it, maybe give alectinib first and on progression lorlatinib. The other thought process would be to give lorlatinib first because have a better PFS and OS. So both are correct options in this regards. But ALK fusion variant as well as the underlying morbidities, and as rightly mentioned, radiation, post-radiation there would be more toxicity. Considering all these factors, one would look at the choosing the drug in this patient.
Thank you. Dr. Mukesh, any thoughts?
Thank you, ma'am. First of all, as all of them have told, the NGS panel before starting anything, because radiation is going on, I will consider for the NGS panel. I have to check for the other mutations like TP53, other mutations also we need to check whether there's poor prognostic factors are there or not. Third thing, I think we talk about always being a medical oncologist, PFS, OS, but we less talk about the quality of life of the patient. See, we know the patient is radiated, we want to give the drug which has the highest PFS benefit. But if at cost of the troubling quality of life, neurocognitive disturbances, suicidal thoughts, other troubles, the patients will come to you and he will say, what you have given, sir, this has all created more trouble than the disease. Because patient's family doesn't understand sometimes the disease, they understand only the symptoms which the patient is facing. So I think quality of life of the patient is actually very important when we consider these two drugs, because we know one has a good data of PFS, very good data, I think very good data of PFS, and one has yet the OS data, but definitely PFS data more with lorlatinib. I think quality of life is very important. We should consider. I think there is a meta-analysis which has shown that the Asian descended population, they respond, I think, better to alectinib than the lorlatinib. There is a meta-analysis, I think. So that is also one point where we have to see the heterogeneity of the population. And these are important points, and definitely we have to discuss these points. And considering both all these NGS panel, other mutations, TP53, and all those things, considers the treatment option among both alectinib or lorlatinib.
Thank you. Thank you for your opinion and also outlining why you would choose what you would choose. Some facts to mention. I mean, if you look at this particular study, the LORLA-2 study, essentially here we point out that lorlatinib given in the next few lines of therapy may also be adding equally to the survival advantage. And here you have the data wherein there is nearly 100 months being added to the life of a patient in the next lines of therapy. So now, is this a paradox? Because we've always said in oncology, use the best drug first. Okay? So if you see the PFS from the CROWN study and you see the LORLA-2 data where in subsequent lines you're utilizing, there is a message that comes through. This drug is active in the next several lines as well. In that situation, when we choose the frontline therapy, most of you have said that you will look at the toxicity profile, correct? So before I move to discussing toxicity profile, I go back to the editorial which says ALK positive NSCLC is a forgiving disease, and that's for anyone and everyone, whoever is listening. This has been my personal experience as well. You switch the therapy as long as the drugs are able to penetrate the CNS, because you're talking about 40% of disease going to CNS. So the drug has to cover CNS. As long as the disease is being covered in the CNS setting as well, one has to then look at which drug would be better tolerated by the patient, because this is not a situation where mostly in the next line of therapy you will not be able to use a particular drug. So best drug first, that terminology is great, but not essentially meaningful in cancelling the utilization of lorlatinib as the second, third, fourth, fifth line setting. So that's where the terminology of forgiving disease, this is a forgiving disease. So you have other line options to utilize the same drug that is being presented in the frontline setting. So question, the fact that lorlatinib has been documented to give such a survival advantage in the next line setting, does it make you comfortable or it doesn't matter? The current data matters, and if current data matters, then the 5-year OS data is with alectinib vis-a-vis the fact that the lorlatinib data is still maturing. What really helps you out here?
So if I can answer this.
Please.
So as we all have discussed previously, all of us have come to the conclusion that mainly toxicity, it is all going to revolve around toxicity. And the crown data is really tempting, no doubt about it. And if we see that a 5-year PFS only has not yet been reached with lorlatinib, so obviously 5-year OS is, or maybe is going to be better. But having said that, the established evidence says that lorlatinib can be given in the second line. If we just do a maybe addition of whatever PFS we can achieve with alectinib, roughly around 34-36 months with the first line, and then in the second line lorlatinib is somewhere around 7 to 8 months. So roughly around 42 months of PFS or advantage of survival which we can get theoretically. But having said that, lorlatinib on paper is going like beyond 5 years, the PFS has not been reached. So it all boils down to the toxicity and choosing our patients rightly. So that's what I feel matters in our clinic.
That's a very important point made here, that when we compare the survivals, I think a lot of this is going to come out comparable. And I also feel it's a time to rejoice because you have all these options to choose from, and especially when you look at the options from a patient perspective, it is true that today we have all these options and we have to choose our drugs very carefully, both from a efficacy as well as toxicity perspective. So with that, I come to Preetham. In your practice, Preetham, what percentage of patients would present with brain metastasis? Do you really see the 40% that is talked about? And also, do they come pre-treated? Do you get the chance to see them before they get treated for the brain metastasis? Or there is a certain percentage that may result in your practice already treated? And I'll ask the same question to Dr. Roop.
So madam, one of the things that comes to our this thing is that 40% may be a bit higher value because we generally may not do MRI brain for a lot of patients who are asymptomatic. So maybe 20 to 30% patients may be coming with the brain mets at the baseline, those who have asymptomatic brain mets, or they are caught accidentally on the PET scan. And many of these patients, nowadays, because they are asymptomatic, they may not be treated with the radiation therapy in this present times. While before, 4-5 years before, maybe they would all receive radiation or they may be receiving chemotherapy and all these things. So now I think we see a lot of patients who are not pre-treated with radiation to the brain, and that's a good news. Well, to the previous question which you asked, ma'am, so the same discussion is there. 4-5 years before, the discussion was there whether we add, like for the breast cancer, whether we add palbociclib in the first line or we add in the second line, the outcomes are the same. But now, as we all know, we use CDK4/6 inhibitors as the frontline therapy. So the best treatment comes the first. That is what we all have been taught for. But yeah, the morbidity profile and everything and the side effect profile needs to look into.
Great. Dr. Roop?
So around 30% of ALK positive patients will have brain mets, and in clinical practice also we see that. And if the patient is asymptomatic, we do not give RT.
Do you get patients who have already received brain radiation?
Yes, but around 80% of the patients will not have RT prior.
Will already have had RT or not have had it? Not had. You have the chance of giving them the right recommendation. Okay, Dr. Mukesh?
I think I agree. 30 to 40% patients probably comes with the brain metastasis, and I think it depends upon where you work, and if you have an institute practice, definitely the patient comes to you first before going for radiation, but sometimes few patients come post radiation to us.
Thank you. So, I think all of us work at centers where people are becoming more cognizant. So, yes, there is a significant percentage of patients with ALK positive disease that presents with brain metastasis, but our respective practices are cognizant of the fact that the brain mets don't reflexly need to be radiated. They are talking to the medoncs. They're trying to figure out if there are newer drugs that would help with the disease control. And with the same focus, today we have additional data with overall survival according to the CNS status at baseline in several of these studies, including the Alicia, the Alex, and now we also have the Crown data, which is essentially not reached. One of the things that has come to our knowledge, understanding, especially because of this paper, is the fact that if the patient has had a prior brain radiotherapy, as was mentioned by Dr. Rup initially, if the patient has had prior brain radiotherapy, that the neurocognitive side effects are more pronounced. So if you look here, cognitive effects are 44% versus 26%. So all across NEAEs 67%, 41%. So there is significant difference in numbers are small, but we have to understand that if there is prior brain radiation, there could be essentially additional neurocognitive issue with lorlatinib. We just have to be mindful of that. So psychotic features, mood effects, speech effects, all of these are parts of neurocognitive issues that can arise with lorlatinib. Having said that, any takers here to neurocognitive issues that you may have seen in a patient of yours?
One patient had a suicidal tendency after starting around 2 weeks later.
So thank you for sharing.
One of the patient had mood swings, so that was one of the patient I remember.
Yeah. So mood swings I found in my patients were one of the commonest side effects of lorlatinib, but you obviously have to pre-warn the patient of the entire spectrum of neurocognitive issues that may happen, because that may just be taken. So one of the areas where I started utilizing this medicine was in brain metastasis. Especially if, so the whole post-RT data came through, right? All of us took up and the patient may be getting radiation, may not be getting radiation, and that's where we were pitching the drug. But then a lot of the neurocognitive issues may just get camouflaged by thinking it is as a result of the radiation the patient may have received, or as a result of the primary issue in the brain, which is the brain metastasis. So we all need to be really aware of this fact that the patient may actually be having neurocognitive issues from the medication, and what needs to be done for that, either stopping the drug, giving the patient a treatment break, restarting at a lesser dose, or sometimes in certain very stark situations you may not be able to go back to the drug. That plus all the other toxicity profiles. So now we have also started talking a lot about the variants and different variants of the fusion and co-occurring p53 mutation. And in that we are having, so this particular study, which is a real life study, actually has highest number of alectinib treated. We don't have that large number of lorlatinib treated patients yet. So you have a little more clarity in terms of the variants and the data around the variants with this Guardant informed database study, where in different variants were described as per the liquid. And this is a very nice slide made with comparison between plasma and tissue and different variants having different survival with alectinib. We are still awaiting an in-depth data for the variants post-crown. Some data is already available, but more mature data is being awaited. So that said, I think we have all homed into the safety. And in the 3 major studies that we discussed, ALEX, JALEX, Alicia, we had a certain percentage of toxicity cited. If you look at the discontinuation rates, it's in the range of 12 to 14%, both in the ALEX study as well as the CROWN study. But if you look at the real life data and what percentage of patients discontinued, the RE-ALEX study focuses on this, and actually it's a very different number that comes across. So it's 0.9% discontinuation rates due to toxicity profile. And so one of my last questions to you would be, in terms of I think we'll take some time, it'll take a while for us to come up with this loads of experience with lorlatinib, right? And general feeling, do your patients discontinue with the drug, right? But do you have that sense with alectinib? Do you have a general sense? If your patient goes on alectinib, do you worry?
Yeah, most of them generally well tolerated the drug, alectinib.
And do you recall patients who have had to discontinue, and how many do you recall? Do you think there were many patients?
One patient had grade 3 hyperbilirubinemia. So we hold it and restarted on 300 milligram BD.
This you're talking about lorlatinib?
No, alectinib.
Alectinib, yeah. Okay. So one patient you remember, right? Any others?
Same experience here, fairly well tolerated. Only recently, one of my patients with alectinib had hyperbilirubinemia.
Right.
So I had to step down, hold it and step down, and then again he is tolerating it well. So overall, we are not worried much about alectinib, and lorlatinib we really need more data and more clinical experience to be comfortable.
Preetham, the same?
Yeah, same.
Yeah?
Yeah.
Okay, so I think our patient got treated with alectinib. The resistance pathway on alectinib is also well understood by now, a lot more information on that. And we know that a lot of alectinib resistance can be tackled with lorlatinib. Can't say the same. Lorlatinib-induced resistance are much more complicated. We are still struggling to find the drugs to tackle the mutations that are seen on lorlatinib resistance. And of course, the last slide here, which says 2 things. And that's what I have taken home from my last presentation and this one. ALK positive NSCLC is a forgiving disease, and toxicity matters. These are the 2 things that editorial enlightens us with, and it also goes on to quote a patient advocate who said, if you have lorlatinib in that package, you need to also figure out a psychologist. So I leave you with that, because I feel the numbers are going to grow in each one of our practices. And we have to roll up our sleeves and be very careful when we advise lorlatinib. We have to be receptive, we have to be mindful. And I'll finish this by saying, you know my personal preference when I'm moderating this session. So thank you so much. I've always leaned on alectinib over the last decade, I would say. I found it a very safe drug. So just as a moderator, I don't worry a whole lot when I have a patient on alectinib. But of course, with lorlatinib, there are certain processes in place. This doesn't mean to say that we shouldn't be giving a drug that has a toxicity profile. We've all given afatinib, right? We've all given dacomitinib. So poziotinib, pyrotinib, these are very, very tough drugs. So we've all given tough drugs. That's needless. But you have, in the same bracket, you have a comparison. So the message is, do not abandon a first-line drug just because there is another contender that has come into that space, alectinib still remains standard of care, frontline, and still is a very valuable drug. Choose your patients, choose the time you need to give lorlatinib, which will come with additional toxicity. These patients will live many, many, many months, years together. You can sequence because the sequencing also will yield similar benefit from lorlatinib. Thank you so much. Thank you, my panelists. Dr. Mukesh, I couldn't come back to you for the last question, but thank you for joining in, and thank you all of you for coming in this evening. Thank you.